I'm Dr. Subroto Chatterjee. I'm a professor of medicine and pediatrics, cardiology division at the Johns Hopkins University School of Medicine. I just gave a presentation at the International Academy of Cardiology meeting, and I'm just going to briefly summarize what I presented. So as most of us know and appreciate, atherosclerosis is very common in the Western countries, and now it's spreading worldwide like an epidemic. And cholesterol seems to be one of the major factors that contributes to atherosclerosis. And I think that the major discovery in the 20th century was the finding of the statins, which were used to lower cholesterol, and they're highly successful and saved many lives. But over the years, use has shown that it has many side effects. And these includes allergies, muscle pain, joint pain. And recent studies show that prolonged use in some patients, almost like 9%, they can develop diabetes and some ocular disease as well. So essentially, when statins were designed, they were designed to focus on one enzyme to regulate cholesterol metabolism, which is HMG-CoA reductase. And so naturally, it does not take care of cholesterol metabolized by other pathways and so forth. And so we did some marketing analysis, and it showed that about 10 million Americans fall into that category who could benefit from drugs other than statins. So our strategy at Johns Hopkins is to think about drugs that have multi-targeted approach to lower cholesterol levels. And our work began almost like 3 decades ago when we were treating, before the statins, we were treating patients with familial hypercholesterolemia by a method called plasma exchange therapy. So that involves drawing a unit of blood, saving the plasma, and thereby reducing cholesterol levels, and also giving the red blood cells back to the patient. So we observed that after plasma exchange therapy, the cholesterol levels in these patients fell almost like 30–40% in the serum. But in tandem, when we analyzed the urinary sediment cells, these are proximal tubular cells that are shed, the level of not only cholesterol but also a glycolipid called lactosylceramide also reduced along with cholesterol. And when plasma exchange therapy, after several days afterwards, as cholesterol rose, so did the levels of lactosylceramide. So there was some kind of relationship. And then over the last 2–3 decades, we discovered drugs, compounds that will inhibit the synthesis of this compound. And we showed that in both cell-based experiments and in many animal models, this drug will block the effect of various situations, diseases, so forth, that cause cell proliferation, angiogenesis, migration, cell adhesion, and so forth. Now, all of these phenotypes are involved. These are the hallmarks in atherosclerosis. It's a build-up towards atherosclerosis. So once we got a large, multi-year funding from NIH, we decided to use this drug in a transgenic mouse model called ApoE knockout mice. And so when these mice are fed high fat and cholesterol, they develop atherosclerosis. In other words, their blood vessels get blocked by high fat and cholesterol and various other goodies in the circulation. Conversely, when these mice were fed orally our compound inhibitor, there was a dose-dependent decrease and almost complete reversal of atherosclerosis and plaque formation. And then we looked at multiple genes that regulate cholesterol homeostasis and various byproducts. And we found that not only cholesterol synthesis was inhibited, but also cholesterol efflux, the transfer of cholesterol from peripheral tissues back to the liver, that was increased. And most importantly, once these cholesterol reached liver, they were converted to bile acids much more efficiently. And that's the exit strategy. That's how we are getting rid of cholesterol in these patients. So these observations suggested that this is the mechanism how our drug works. It targets multiple sites that are involved in cholesterol homeostasis and thereby reducing the whole process. So while these were encouraging results, but the cost of doing these experiments was rather high. The drug alone was costing us about $15,000 per experiment. So what we did is we collaborated with my faculty in the Department of Biomedical Engineering, and we encapsulated our drug within a biopolymer. And that did two things. First, it rapidly increased the rapid absorption of the encapsulated drug when given orally to mice. And second, it allowed the drug to stay around and in the circulation much longer. For example, if the native drug is given, it is completely metabolized within 1 hour. When it is encapsulated with the biopolymer, then it can stay in circulation up to 24, 48 hours. So that increased the efficacy by which our drug was working, and also increased the turnover time as well. So with that, we could prevent atherosclerosis and also interfere with atherosclerosis. So if the plaques were already built up, we treated these mice with this biopolymer encapsulated drug, and we could reverse it. One more exciting finding came out of this study is that in addition to atherosclerosis, we noted that the left ventricle and the heart of these mice the size were a lot bigger, and this is called left ventricular hypertrophy. So that was increased upon fat feeding cholesterol, and upon treatment with our drug, it could be completely reversed. And so fractional shortening is other measure of cardiac hypertrophy, and we also looked at multiple genes, natriuretic genes, that are implicated in cardiac hypertrophy. So by use of various cardiovascular measurement technology, biochemical technology, and molecular technology, by all three means, we could show that this drug is also effective in reducing cardiac hypertrophy in mice that are fed high fat and cholesterol.